We've heard a lot about neuroprotective therapies, particularly from Dr. Calabresi's talks, and Dr. Keswani is going to introduce us to some of those, including the new EPO trials that are about to start.
Thank you, Sandy. I'd like to speak about potential neuroprotective therapies for MS and transverse myelitis. I should add that I recently transitioned from Johns Hopkins to Amgen, and this is really all the work that's being done at Johns Hopkins, and it's not an Amgen-sponsored talk. So just to give people an idea of the anatomy, as it'll help understand some of what I'll talk about later. In particular, I'd like to show the axon, which is essentially the nerve fiber, and is the way that neurons communicate with its target tissue, such as muscles, as well as other neurons as well. Now, we feel that permanent disability in multiple sclerosis and transverse myelitis is most likely due to axonal loss, i.e. loss of nerve fibers. So we know that inflammation is important in both multiple sclerosis and transverse myelitis. We know that demyelination is important, but with respect to what causes permanent disability, it's the subsequent nerve fiber degeneration or axonal loss that is critical for mediating permanent disability. For multiple sclerosis, this idea of axonal degeneration hasn't really been a prominent feature or recognized as a prominent feature till fairly recently, in the last 10 years or so. And we know that as time goes on, there is some atrophy of the brain. And that atrophy is thought to be due to axonal loss to a large extent. And what one sees in plaques in patients with multiple sclerosis are evidence of cutting up of axons, as shown in the left slide by those arrows. Those are spheroids, and basically when axons and nerve fibers are cut up, the ends swell. Now, studies like this haven't been done in transverse myelitis, but it's suspected that something very similar would be seen. This is another example for multiple sclerosis, spinal cord MS plaque. On the left, one can see the normal nerve fiber density running through that plaque. On the right, you can see the density is much reduced. Again, no similar data for transverse myelitis yet, but again, we would anticipate it would look very much like this as well. Something that we see in transverse myelitis, in addition to multiple sclerosis, is darkness on T1 sequences, or T1 hypodensity. And it's been shown that the degree of this darkness, this hypointensity on T1, correlates with the degree of nerve fiber loss. So in terms of how one gets axonal degeneration due to an inflammatory insult that occurs in disease like MS and transverse myelitis, macrophages and microglial products are thought to be important. So, for example, nitric oxide and glutamate may be relevant. Agents released by astrocytes may also be relevant, antibody and complement, and also cytotoxic T cells, which are known to infiltrate plaques in MS and are known to be in transverse myelitis lesions as well. Now, much more relevant to multiple sclerosis, which is a more chronic disease than transverse myelitis, there is also chronic axonal loss that, which occurs due to demyelination of axons. It seems that this myelin or insulating sheath around the axon is important in keeping that axon healthy. And when one loses this insulating sheath, one has a vulnerable nerve fiber that is susceptible to degeneration. So in thinking about how one could combat axonal degeneration, one could think of agents that are indirectly neuroprotective and agents that are directly neuroprotective. So indirectly neuroprotective agents would include anti-inflammatory agents, and that's essentially intravenous steroids, for example, or other anti-inflammatory agents. Some of the immunomodulating agents are approved for MS. And that's obviously based on the premise that if you modulate the immune system that is attacking these nerve fibers, then one should prevent this nerve fiber damage and degeneration. There's a lot of work going on specific therapies to various cytokines and chemokines. It's hoped that some of these therapies that are being looked at in multiple sclerosis could be translated over to transverse myelitis. Agents promoting remyelination, for example, LINGO inhibitors, is actually being discussed in the scientific portion of the conference. This is still pretty early in terms of clinical development. If one prevents death of oligodendrocytes that make myelin, that would be helpful in terms of preserving nerve fibers. And then one could look at directly neuroprotective agents. So these are agents that intrinsically make the axon stronger or more resistant to degeneration. So they include neurotrophic factors, erythropoietin, which I'll touch on later, and also sodium channel blockers. And the reason I mention sodium channel blockers is that when an axon loses its myelin, its insulating sheath, then one gets a redistribution of sodium channels along that demyelinated segment, which predisposes that nerve fiber to degeneration. So if one could block the sodium channels, then that may be helpful as well. And then agents preventing neuronal death may be helpful as well. So I could title this slide Strategy to Prevent Axonal Degeneration, MS, as well as Transverse Myelitis. In terms of thinking how one could combat axonal degeneration, one could modulate the immune system, which is what I mentioned in the previous slide. One could try and remyelinate this demyelinated segment, which is number 2. One could prevent oligodendrocyte death from occurring, and that would hopefully lead to more myelination or remyelination. And one could make this axon more inherently resistant to degeneration, which is indicated by number 4. So there's work going on in each of these 4 areas. So it's become apparent in inflammatory demyelinating diseases like MS and TM that you need an agent that is both immunomodulating but is also neuroprotective as well. So with respect to the design of neuroprotective agents, we really haven't done this well before in really any other disease. I think the real example are stroke trials where people have used neuroprotective agents to prevent infarcts and looked at clinical outcome. But for demyelinating diseases, there is no standard template for how you would test a neuroprotective agent. And that's because we don't really have good measures of axonal function or axonal integrity yet. But as the previous speaker indicated, there are imaging markers that may help us with that. Now, one of the major differences between multiple sclerosis and transverse myelitis is that MS tends to be a relapsing, remitting, more chronic disease. Transverse myelitis tends to be acute or monophasic. So in terms of when you would give a neuroprotective agent, there is a much longer therapeutic window in multiple sclerosis because disability accrues slowly over time and axonal degeneration happens slowly over time. In transverse myelitis, it would be critical, this is an acute transverse myelitis, it would be critical to give that neuroprotective agent right during the inflammatory insult, during the period of inflammation. The idea being that you're going to give your anti-inflammatory agent anyway, for example, intravenous steroids, but if you could help prevent the axons from being cut up and destroyed by this inflammatory insult, and then you ride out this inflammatory episode, then there'll still be axons there to remyelinate, and that hopefully will prevent permanent disability in transverse myelitis. So I've lumped them together, but when you would give your neuroprotective agent would be very different in these two disease entities. In terms of how you would measure how well a neuroprotective agent is working in transverse myelitis, I think it would be relatively simple. Clinically, it may be how much disability there is on a score like the MSFC or the EDSS, the number of patients who, for example, need a walking aid or a wheelchair bound. Ideally, that's what we'd like with our neuroprotective agent. The previous speaker covered a lot of the imaging biomarkers that one may think about, and so I won't go through this in much detail, except to highlight diffusion tensor imaging, which may be a very good way of looking at axonal integrity in the spinal cord as well as the brain. And this is an imaging modality that is being considered in the soon-to-start EPO trial in transverse myelitis. With respect to the optic nerve, optical coherence tomography is something that a lot of people are talking about. We know after optic neuritis that there is some retinal nerve fiber loss, and that could be detected with this non-invasive technique called OCT, optic coherence tomography, which works kind of like an ultrasound. One could therefore, if one wants to get proof of concept of a neuroprotective agent in disease like MS and TM, try it in patients who've just had optic neuritis and see if you see prevention of a decrease in retinal nerve fiber layer thickness using optical coherence tomography. I'll just skip over that. With respect to multiple sclerosis, there are currently available therapies for multiple sclerosis, and I think for a neuroprotective agent design, one would have to add it on to existing therapies. I don't think anyone would want to have a placebo-controlled trial where one set of patients not receiving any therapy at all, particularly as you know there are therapies on the market that are helpful. And these studies would be very long. Like a phase 3 study would be long, like more than 5 years, we think, if disability is all that we had in terms of measuring efficacy of neuroprotective agent. In transverse myelitis, in contrast, this trial does not have to be long at all. So I'll just move on to erythropoietin, or EPO. This is a hematopoietic growth factor. And traditionally, it's been described in increasing hematocrit. And so patients, for example, who are anemic, whether because they are receiving cancer chemotherapy or because they have HIV or any number of reasons for anemia, they can take erythropoietin to increase their red blood cell mass. But of note, it was found out recently that there is actually a lot of EPO in the nervous system as well, and also receptors for EPO on nervous tissue. And indeed, this endogenous EPO is important, we think, in natural or endogenous neuroprotection. So ischemic preconditioning is whereby a patient is relatively protected from a larger stroke if they have had a preceding small stroke or smaller hypoxic insult. That's thought to be because astrocytes have EPO turned on. And we know even in the peripheral nerves that cells produce EPO, and that can also help to combat neurotoxic insults. So that's why we think EPO is there in the nervous system. It's not just in our bodies for increasing red blood cell mass, but also maybe an endogenous or natural neuroprotective agent. So There's been a lot of work on EPO showing that it is neuroprotective. This is just one example of a study that was done at Hopkins in our lab. And this is a model of peripheral neuropathy where there's fairly pure axonal loss. And these animals, after they get this toxin, essentially get weak, and also they lose their sensory fibers as well. And basically on administration of EPO, one could largely prevent the problems in sensation and pain, and also improve their grip strength as well, or their or loss of weakness induced by the toxic agent. It's also been shown to be protective in spinal cord crush injuries, in rats, in ischemic injuries to the spinal cord, and also in an inflammatory demyelinating model, EAE, in rats as well. So I just want to move on to the proposed clinical trial of erythropoietin in transverse myelitis at Johns Hopkins. This is a single-site study. It's anticipated that 30 patients with acute transverse myelitis will be enrolled, and 2 doses of erythropoietin will be given. This will be 2 weeks apart. The first dose would happen fairly soon, or as soon as possible after the onset of symptoms, with the second dose being given 2 weeks later. All patients will receive their conventional immunomodulating therapy. And really the standard of care is intravenous solumedrol, so everyone would get a 5-day course of IV steroids. Because remember, we think that an anti-inflammatory action combined with a neuroprotective approach is really the way to go. And outcome measures would include safety. So the major thing that we would worry about when one gives erythropoietin is a rise in their hemoglobin. We don't want a huge rise in hemoglobin. If you get a huge rise in hemoglobin, then you may be more predisposed to strokes. So that's something we have to worry about. But we feel with this particular dosing regimen, separated just 2 doses separated by 2 weeks, we should be okay. But obviously this is something that we need to watch out for carefully. So patients will have regular hematocrits to look at their red blood cell mass and hemoglobin. And then there'll be functional measures of disability like the EDSS, which is commonly used actually in MS trials, and the MS functional composite, which might be actually a better score to use in patients with transverse myelitis, as it's particularly weighted towards difficulty in walking. And then we have this fairly exciting tool, diffusion tensor imaging, which may help us quantify axonal loss as well. So this combination of outcome measures should really help to rigorously test in this is a small pilot trial really, but it would help us to detect if we see a significant treatment effect of EPO. So in summary, multiple sclerosis and transverse myelitis, they're inflammatory demyelinating diseases, but of note they have big components of axonal degeneration. And axonal degeneration plays a major role in causing permanent disability. With respect to MS, there are currently available immunomodulating therapies, but they have a pretty modest effect on disability. So neuroprotective or really axonoprotective therapies are needed to prevent disability in these diseases. And these could be used in combination with immunomodulating agents. And I talked a bit about how one may approach the clinical design of a neuroprotective agent in multiple sclerosis as well as transverse myelitis. Thank you. Suppression versus immunomodulation, what's the difference? And his point was really most of the immunosuppressants we use are all immunomodulating. It's pretty rare to have an immunosuppressive agent that suppresses absolutely every component of the immune system. I mean, even Cytoxan, for example, it suppresses some cells, but then it increases cytokine release from other cells. So essentially, all the immunosuppressive agents that we use are really immunomodulating. But I think with respect to transverse myelitis, the acute inflammatory insult is usually very severe. And I think it's important to get a handle on it fairly quickly.
Has the erythropoietin been used for any of the sensory peripheral neuropathies from chemotherapy in humans?
Yeah, that's a good question. So there are currently 2 erythropoietin trials that I think are currently enrolling. The first is in cancer-induced chemotherapy. I think these are patients who receive Taxol, and before they get their Taxol, they're given erythropoietin, and then they're followed up to see if the administration of EPO prevented Taxol-induced neuropathy or peripheral neuropathy. So that's one study. The other study is erythropoietin in acute stroke, and this has been done in Germany. They've already enrolled several patients, and we're hoping that we'll get the results of this study early next year. Then in terms of upcoming trials, there is an EPO trial in HIV neuropathy that actually I was involved in, and it's actually a 5-site study which is funded by the NIH, and that should be enrolling later this year. And this is a more chronic study. This is a 1-year study, and this will really get at how safe erythropoietin is with respect to chronic use.